Good afternoon. Welcome to the Cardiovascular Conference hosted by Vascular Surgery this month. I'm going to talk about the diagnosis and the endovascular treatment of chronic mesenteric ischemia first, and then Dr. Tan will talk about the vein mapping for pre-op evaluation for AV access. Okay, let's see. Well, we have a remote control can. Anyway, we just okay. Chronic mesenteric ischemia is different from acute mesenteric ischemia. This is mostly over 90% patients due to atherosclerosis and a decrease of perfusion to visceral organs, especially intestine. So you can see this, some blockages in the visceral artery that decreased perfusion and caused clinical presentations. Let's see what chronic mesenteric ischemia patient present with. The typical presentation including triads of visceral ischemia, which means pain after eating. Usually it's in the epigastric area or periumbilical area after eating 30 to 40 minutes after, and it can last probably 2 hours. Okay. Fear of eating because of pain after a meal and weight loss. Patient cannot eat, cannot take the nutrients from food. That's a typical clinical presentation. If you see a patient in clinic, most time the primary care physician send to you, but sometimes you see patient. And oncologists probably see patient more often with chronic abdominal pain or weight loss, and they worry about cancer, and actually patient may have chronic mesenteric ischemia. If you worry about this, now you can do a screen study. Ultrasound can be used as a screen study. Patient should be fasted, and you can check SMA and the celiac. With duplex ultrasound, you can see the color change, so you can see the turbulence, and you can see waveform changes, and also lost the window, after this spectrum. Okay, behind that. The velocity is increased because of stenosis. For SMA, peak systolic velocity greater than 275, and the end diastolic velocity greater than 45. And the celiac artery is a little different with different numbers, so you don't have to remember this, but the ultrasonographer and a radiologist, they have a criteria for this diagnosis. CAT scan. CT scan is a choice of the imaging study. If you really worry about the patient may have chronic mesenteric ischemia, then CT scan will be the study for diagnosis. It can give you direct evidence of visceral artery disease, like this from an axial cut. You can see this is a celiac trunk occlusion, and from a lateral view, you see celiac and SMA disease. And you can see with this good reconstruction AP view, you can see all these collaterals. And if you do see this, sometimes you cannot see the orifice occlusion or stenosis because of the overlap, especially for traditional angio. But if you see these collaterals, you really need to worry about patient may have some disease in celiac or SMA or IMA. And like I mentioned earlier, a lot of patients present with weight loss and abdominal pain. You need to rule out cancer, tumor patient, and a CT scan can give you evidence of associated pathologies. And also some patient with acute ischemic change on top of a chronic disease, and you can also see from a CT scan with 3D reconstruction. Conventional angio, DSA, is good, but it's invasive. The advantages for DSA is diagnostic and therapeutic. It can treat a patient at the same time. But the disadvantage, like I said, is invasive. You can have procedure-related complications. You can have an embolization. You can have a puncture set, a hematoma, and bleeding, and it can have kidney problems and also contrast-related complications, including kidney issues and allergies stuff. So again, when you do DSA, you should always do AP view and a lateral. AP view, you can evaluate collaterals, and the lateral view is even more important, which tells you where the occlusions are and how severe the disease is. Traditional treatment, so open surgery, you can do bypass, either antegrade or retrograde. Retrograde probably used more often, so you can use iliac artery as a feeding vessel to reverse the C bypass. If the chronic mesenteric ischemia with bowel infarction, then it's a clean area, and you can use an artificial vessel or you can use a vein graft. But for extra anatomic bypass, usually artificial vessel has a better patency than vein. But if the patient has a bowel infarction and or even perforation, it's contaminated area, then you always use a vein graft. Or you can do, if it's a short segmental disease, you can transect the artery, resect the piece of the artery, and then reimplant to the aorta. And like this, or you can do a bridging graft, or that's an antegrade bypass. But usually we need to mobilize the pancreas and pass this graft underneath. It may cause some damage to the vessels and the pancreas. This clinically used less than retrograde bypass. So open surgery, no matter what you use, different procedures, then they have a similar equivalent clinical outcomes. The long-term patency and preoperative mortality and morbidities and the recurrent symptoms are pretty much the same. Okay, you can choose either antegrade or retrograde bypasses based on your preference or experiences. Now we do this open surgery less and less because now we have an endovascular technique available. Okay. Now let's spend a little more time about the endovascular repair, endovascular treatment of chronic mesenteric ischemia. You can do PTA or stenting. So the first PTA of SMA was reported in 1980s, and since then, more and more patients went to endovascular treatment for mesenteric ischemia. Clinical studies, almost all clinical studies shows, let's see the comparisons. So for primary patency, of course, open bypass is much higher than endovascular. But for secondary bypass, which means after you repeat another procedure or stent, and the long-term patency is comparable in both procedures. So this is a study. It's a nationwide inpatient NIS sample done by Schermerhorn from Harvard Medical School, and he reviewed this chronic and acute mesenteric ischemia. Today we focus on this chronic mesenteric ischemia. For endovascular repair, total 3,500 cases, and for open surgery, it's about 2,100 cases. Based on study, we can see this. The perioperative mortality for open repair remains above 20%, and the endovascular repair is less than 10%. We just mentioned, so the long-term patency is better in the open repair group. However, the preoperative mortality rate is much lower in the endovascular treatment group. The procedure numbers, so the open surgery remained pretty steady, maybe a little decreased. However, you can see this endovascular procedures are significantly increased since 1995. So now we talk about this. So we know endovascular procedure is the first choice for most of the chronic mesenteric ischemia patient. Now I want to talk about this and try to answer all these questions. The first is when to intervene. So what patient will need a treatment? So how can we treat them? The indications for chronic mesenteric ischemia. So high-grade stenosis of mesenteric arteries with symptoms. For symptomatic patient with pain after meals, significant weight loss, those patients need a treatment. For asymptomatic patient, you find the patient have a mesenteric or celiac ischemia, but incidentally, patient had a CAT scan for something else, and you found this. Do you need to treat them or not? If it's just a one vessel disease, you probably can safely watch the patient. But if it's two vessels get involved, even if the patient is asymptomatic, we still recommend to treat this patient. Why? Because the study showed within a couple years, 30% of patients may develop acute ischemia with bowel infarction, and the patient can die from that. That's indications for chronic mesenteric ischemia. The second question is, how many vessels do we need to treat? Patients are symptomatic. You decide to take a patient to OR for endovascular approach, for endovascular treatment. How many vessels you need to open? That's based on the previous publications. Reportedly, it's 1.4 to 1.8 vessels were treated. Means a lot of patients received just one vessel revascularization. Single vessel revascularization usually is adequate to release these symptoms in most of patients. But two vessel revascularization with a better outcome. So if you can easily to open two vessels, then the progressive or inflammatory disease, should be used for progressive or inflammatory disease, and with a low risk of a symptom recurrence and a secondary intervention. So if you can open two vessels, long-term outcomes better than just one vessel. But if one vessel is totally chronic long segmental occlusion, it's hard to open, then one vessel, celiac or SMA, usually is enough to improve the patient's symptom. Access. When you do an endovascular repair, you have different options. Some physicians like to go from a femoral, from a below, and access the vessel. Some like to go from above. So it depends. My experience is if you have just narrowing, not total occlusion, especially you have a stump over there, I can go from above and then use the catheter, like this type of catheter, to hook to the little nipple stub, or through this, the narrowed lumen to access the vessel. But if it's total occlusion and you need a pushability, I like to go from above, from a brachial artery, and you can see with this angle, and you can push better. Okay. So once you got access, like I mentioned earlier, you always do anterior and lateral view. So what's going on here? But anyway, I think this computer probably, I don't know, doesn't have enough memory or. Okay, I'm not gonna play this video. So it's basically, anterior view, AP view, you can see significant collaterals developed between SMA and IMA. And this is lateral view, you can see the severe stenosis at the arch of this celiac artery. Okay, crossing the lesions. If you have a total occlusion, how do you cross this? Like I said, if it's narrowing, even if that's a very small lumen, you can always pick up a glide wire or 014 wire to cross. But if it's total occlusion, it's always challenge. You need a lateral view to localize where the opening of the proximal vessel of the artery is, and where the occlusive lesions is. And you can, if you need, you can use room map to help you to guide the wire and a catheter to go. Let's see. Here is this vessel. We can see the macro wire 014 wire is right here. You can barely see it, but the catheter, you cannot go through it because it's so tight the narrow is. Then that's a lesion we want to go from above with a better pushability over the wire. Again, this cannot play, but I push and push, eventually will follow the wire and then come through. So you have a different catheter, so you can choose and different wires. If it still cannot cross, it's not moving though. Wait, this computer is too slow. Yeah, I think I'm okay. Yeah, if it's totally occluded, then you may have to use CTO, chronic total occlusion devices. Okay, you have different choices. You have a true pass, you have front runner, you have interior, and all this you can pick up. Okay, and after that you pre-dilate with a 3 to 4 millimeter to get the room open, and you can put a stent in here. Embolization protection devices, do you need or not? It's controversial. Some physicians like to use, especially if it's just one vessel. SMA is a big supply, and some put a filter in there, but most patients, you don't need it. PTA versus stent. You just do a balloon angioplasty, or you need a stent at the same time, or just use a stent for primary treatment. So the study showed 15% of the patients received just the PTA, and all this was done earlier. Recently, most patients got the primary stenting. primary stenting. So this is a stenting. You put a stent in there. The stent, so with a lower recoil and a re-intervention rate, it's already approved. Balloon expandable stent is better because the self-expandable stent and tend to kind of jump forward a little bit, and it's hard to control. For mesenteric ischemia, it's not in the leg, so you better deploy the stent in the right position you want. So balloon expandable stent is preferred. Okay, and also it can be post-dilated. If you think it's too small, you want to dilate a little more, it can be upsizes. And if the patients had a stent placed and developed in-stent stenosis, then a recommendation is the second intervention, you use a cover stent. Still balloon expandable, but cover stent would be better. Okay, and the post-treatment, post-stent, not the post-stenting. Post-stenting, medical management, and usually we give Plavix for 6 months and aspirin for lifetime. So aspirin already approved to protect the cardiovascular event. So that's what recommendation. You don't have to give a Plavix for lifetime. One of our patients was 2-vessel disease, and we accessed and deployed the stent in there and the follow-up cascade. All right, in summary, the indications for endovascular treatment of chronic mesenteric artery, so symptomatic or asymptomatic with 2 or more vessels getting involved. And one vessel balloon angioplasty and stenting is usually adequate to improve the symptoms, but the 2-vessel treatment is better long-term outcome. Primary stenting is recommended. Balloon expandable stent is preferred. Post-stenting and platelets for 6 months with Plavix and aspirin is lifetime if it's not contraindicated. Thank you very much. Any questions? I'll be happy to answer. Sorry for the computer thing. So okay, yeah. Thank you.
Congratulations for bringing this technology to our institution. Do you see plaque dislodgement distally during your stenting procedure?
So I have not personally seen that, but I reported that happened. That's why somebody said if you just one vessel, 3 vessels getting involved, and 1 vessel you want to open, which is SMA, and you worry about the distal embolization, you put a protection device in there. But not all the patients need that. But some, if I see patient like that, for example, you have a celiac and AMA all occluded, severe stenosis of SMA, I really worry about distal embolization. I may use it, but I have not seen that. Yes?
How far can that stent go inside the aorta, stick in the aorta?
Usually, it's a 3 to 5 millimeters. It's a barrier stent. You can just go like a 5 millimeter. If it's a cover stent, I like to little shorter, probably 3 millimeter. That's no problem. No, yeah. Yes.
Sorry,
Great.
could you also extend your indication for patients who had 1 vessel disease but had a previous colectomy? The reason is that they had a previous colectomy, they probably took out one of the major vessels.
Here is a lot of, I know I cannot, yeah.
So if you had a single vessel disease, but they had a history of a colectomy in the past, even though they're asymptomatic, would those patients also should be considered?
That's a very good question. That's you can, based on the study, based on CTA, based on angiogram. So if you think the collaterals are destroyed by previous study, and with this significant disease, I'll probably go more aggressive.
Yeah.
Yes, it's a very good question. Yes, yeah. Okay, thanks. And then Dr. Tan. Yeah, let me get this what? jet. Okay.
So thank you all for coming. And to answer Dr. Chiu's question, I don't think there's any paper that show you have to do it or you don't do it. I think it should be case by case basis and should be decided clinically. So switching gear a little bit, I'm going to talk about more boring topics compared to Dr. Zang, but I think it's a very important topic. I'm sure you guys are aware because of the transition with vascular lab and also because of our volume, pre-op vein mapping, the ultrasound has increased 2 or 3-fold over the last 12 months. And I would like to thank the radiology department, especially Dr. Adam and Dr. Chada for helping us with the pre-op vein mapping. So I thought I'll talk a little bit about the vein mapping to try to explain what we're looking for and to try to explain our methods, why we try to get vein mapping prior to fistula or graft surgery. During my talk, I'll go through introduction. I'll talk about what we look for on physical exam prior to vein mapping. I'll talk a little bit about what we look for on ultrasound. Talk about the criteria that we use for fistula and graft, and the outcome of ultrasound vein mapping with the fistula outcomes, as well as whether we think that vein mapping should be done routinely in addition to physical exam. And stop me if you guys have any questions. So I hate to sound like a nephrologist, but this is what we face. Over the last 20 years, end-stage renal disease and CKD has been increasing in US and Western countries. The most common form of renal replacement in US is hemodialysis. So hemodialysis. PD is a lot less compared to other countries. So for example, in Asia, peritoneal dialysis is more common than hemodialysis because of access issue. But here, hemodialysis is most common. And then the transplant. Because of the limited kidney organ supply, patients that stay on hemodialysis is going to continue to increase over the last 10-20 years, next 10-20 years. So we know that fistula is the best for these patients for different reasons. One, fistula is cheaper, it lasts longer when it works, and there are less complication compared to graft or catheter. Catheters is easier to put in, it's cheaper initially, but usually their mortality and morbidity is a lot higher for people with catheter. For graft, they're in the middle, but still inferior to AV fistula. Now we are pushing the envelopes because we are trying to increase the fistula rate. However, over the last few decades, people that come through our door are more likely to be sicker, older, has diabetes and peripheral vascular disease. The failure is usually due to inadequate vessels for the surgery. AV graft has been the predominant form of hemodialysis access in US until 2006. This is very different to Europe. In Europe, fistula is the predominant form because it's cheaper for them. But in US, because of reimbursement problem, before 2006, you get paid more if you do a graft rather than fistula. So because of that, graft has been the predominant form of access till 2006. So this is a fistula first annual report. The red is the AV graft, brown is fistula, and this catheter. So our government and the the Medicare realized this is wrong, the practice that we are practicing here. So they changed reimbursement, they increased the initiative. So nowadays, fistula is more common and the graph is coming down. So this is what we want to see. Having said that, about 20 to 30% of patients still require AV graft for different reasons. Either their vein is available or they exhaust all the vein. So about 20% of people still need graft, but the catheter is coming down. Now, how do we do? So we are the red, right? So people in the West and the New England is doing a lot better than us when we talk about fistula rate. So for us, which is network 13, including Louisiana, Oklahoma, and Arkansas, about 56% of people or patient has fistula, and the rest have catheter and graft. Oops. Shreveport is here. So green is the catheter, red is graft, and the blue is fistula. We are pretty bad. Shreveport as a city. We have 50% of fistula rate, 20% of graft, and 26% of catheter, compared to the rest of the network 13. And network 13 is the worst nationally because of these outcomes. We are doing a little bit better last 12 months, but we're still similar to this proportion. So I think it's our role to try to do more fistula, do less catheter for our patient and for ourselves, okay? So these are different fistula that we usually do. This is a radiocephalic fistula, so anastomosis down in the wrist, so radial artery fistula. The next common one is brachiocephalic. In fact, brachiocephalic is probably more common than radiocephalic. So the anastomosis at the elbow, at the brachial artery. The next one is brachiobasilic. Brachiobasilic is usually deep, so you can't do a fistula and use it. You have to move the vein up to the skin for them to access. So a lot of time you involve a longer incision and try to move the vein up to the superficial skin. Femoral loop graft, forearm loop graft, and sometimes we use different veins such as greater saphenous or greater saphenous or the basilic vein and do the fistula. So those that I mentioned are fistula. This is AV graft. Forearm AV graft, which is down here. So brachial artery to brachial vein, cephalic, basilic. So down below the elbow. Brachial axillary, above the elbow. So the brachial artery is the donor, and we go to deep vein, either basilic or X-ray vein. So when a patient comes through my clinic, before getting the fistula, after taking good history, this is what I look for. Number one, I look for cephalic vein. The most common fistula that we usually do is brachiocephalic. So we put a tourniquet on and see whether we can feel the fistula, the cephalic vein. Cephalic vein is usually the vein that the nurses use to draw blood, so down the elbow. That's the one, the big juicy vein that you look for. Unfortunately, that's the vein that we most commonly use for fistula. Now, if the patient is big and the vein are very deep, even with brachiocephalic, sometimes we have to move the vein up to the superficial. So this is all about dialysis nurse. If the nurse doesn't feel the fistula, it's unlikely the fistula will be successful, no matter what you do. You could be the best surgeon ever in the country. If the nurses in the dialysis unit doesn't feel the fistula and cannot access, there's no use. If they are tortuous, it's difficult for them to use for fistula. I look for this. I palpate the pulses to make sure I have good artery for the fistula. I make sure the palmar arch is complete to prevent steal, and I want to make sure there's no proximal arteriostenosis by getting pressure between the both arms. If there are more than 20 millimeter mercury between the both arms, that indicates that there's proximal lesion, and you should look for the cause or the stenosis prior to going after the fistula. On the vein mapping, so when I send a patient for mapping and I look at the report and the picture, these are the things that I look for. I want to make sure the vein is healthy. That's probably the most important thing that I look for on ultrasound. Arterial, usually I know, because if I feel a pulse, I think I'm happy with the arterial inflow. But the vein is the one that I need help on ultrasound. You can do it with tourniquet or without tourniquet. I think we do it without tourniquet, so we look for vein more than 2. If you put a tourniquet on, then you use larger diameter, such as 2.5 for fistula and 4 for graft, to make sure that the fistula and the graft is maturing or can mature. We're looking for absence of stenosis or occlusion. This is very common, especially in forearm because of IV access and blood draw. So on ultrasound, because exam is hard to tell us that information, so usually we look for those on ultrasound. It has to be continuous with the dip system, and there's no central vein stenosis. Remember, these patients usually have catheter. Catheter can cause stenosis. Stenosis, I mean subclavian or brachiocephalic. It's hard to image on ultrasound, but you have indirect sign. If the patient has central stenosis, the fistula is likely not going to mature. And those are the veins that we actually need help to look for on ultrasound. Like I say, artery is less important. If they have good palpable pulse, usually I'm not too worried about those. But these are the things that people look for. You want a healthy artery, so no calcification. The intimal medial thickness has to be very thin. Usually we look for more than 2, although some studies suggest 1.6 is very reasonable. Artery that's less than 1.6, they are unlikely to be strong enough to support the fistula. And we want a good flow. Some people do this, reactive hyperemia. That means they calculate the resistance index by taking systolic, divide by end diastolic, and divide by systolic. More than 0.7, that means the artery is healthy, it's elastic, and can be used for fistulas. So, example of hyperemia. So when you clamp the fist and release, because of local vasodilation, you've increased the diastolic flow. Clinically, very few people use this. This is more for research or to follow outcomes during trial. But this suggests the artery is not calcified and it's very healthy, it's very elastic and good enough for inflow. Now, before I talk about the outcomes, these are a couple outcomes that I'm hoping that to go through. So primary failure. When we talk about fistula outcome, primary failure is the fistula that is created but never been used for dialysis access. So either the flow is not good enough or they occluded early. Included in that outcome are immediate failure. That means the fistula is occluded on the day of surgery. So we come out of OR and the fistula is not working. And it's usually small vein or because of technical problem. Either we backward the anastomosis, the anastomosis is not big enough, or we twisted the vein. Early failure within 8 to 12 weeks, usually because of inadequate vein. So these are the outcomes that we look for primary failure. Some people think this is a better outcome, functional primary patency. That means a fistula that's functioning can be accessed for dialysis without need for further repair or revision. Secondary patency is outcome that we describe when the fistula is occluded and you open it up. So they go for primary patency to secondary. Clear? And these are the outcomes that we usually look for or describe in trials and papers. So when we look at radial artery diameters, there's no absolute numbers, but sounds like if the artery size is bigger, it's better. Okay. If you take the cutoff of 0.5 millimeters, this is usually radial artery because brachial artery is a lot bigger than radial, and usually they are strong enough. So usually people talk about radial artery. If they are less than 1.5, 64% of the fistula does not work. If they are bigger, then a lot of the fistula are better. So same thing, this paper talk about 1.5. Obviously, the bigger the artery, it is better. So for this paper, Silva et al. In 1998, 83% the fistula is successful at 12 months if you use diameter more than 2. Now, all these are limited by patient factors, the gender, and all those stuff. So we all wish that our fistula, the artery is more than 2, but it's unlikely you'll get it. So we try to work whatever is come through the door. Usually we don't talk about brachial artery, but they are usually bigger, so bigger than the radial artery. Although one scenario is if they have high bifurcation. So if they have high bifurcation in the axilla, this might be applicable. So if you have a 3 millimeter brachial or axillary artery and become 1.5, this become very important at the elbow level. So usually we want to know that before we go in, so that we are not surprised. Like I say, these are it's less likely that we use it in clinical practice, but there are some centers that do a lot use it. So they look at the intimal medial thickness, and obviously if the artery is healthy, the more likely your fistula will be successful. We all the thing that we describe about is trying to look at the underlying disease in the radial artery. So that's the main thing. Another thing is we want to know the disease in artery because sometimes it can cause steel after the fistula. And for patients with arterial disease, it's more likely that you have more steel. So those things we have to be careful about. So like I say, some people use reactive hyperemia. And again, if the index is more than 0.7, they are more likely to be successful after fistula. There was one study in 2004 that say hyperemia doesn't really make a difference. But for that study, I think they have selected the patient already. Those patient is the healthy patient or patient with healthy artery. So it's less important, I think. What I look for usually is pulpal pulse, and if they have triphasic waveform, usually I'll go for the artery to create a fistula. Like I say, venous is probably more important during vein mapping. There's no magic number. Obviously, the bigger it is, the better the outcome will be. If you use the vein less than 1.6, everyone failed. More than 2 without tourniquet, so up to 80% will work. So these are the number that we look for. Usually I use 2. I don't know what Dr. Zang used, but I use 2 without tourniquet and 2.5 with tourniquet. And obviously the larger it is, the better it is. Same thing, we want a healthy vein. We want a vein that can dilate when you put tourniquet on. So if they're healthy and dilate, more likely the vein will be successful to mature and become a fistula. I don't think there's any absolute cutoff. In the era that we are trying to get more fistula, we are pushing the limit at the expense of a higher primary failure. So 10 years ago, our primary failure might be low, but overall fistula creation rate is low. Nowadays, our fistula creation rate is higher, but our primary failure rate is higher as well because we are pushing a lot of limits. We are trying to get a fistula going for a patient. So, do we really need to do vein mapping? Do we have to do it before fistula? So these are the meta-analysis looking at all the papers. Selective means if they are not happy with the vein or artery, they get ultrasound. Routine means doesn't matter what the exam show, they get ultrasound. And you can see if you use ultrasound, the higher number of fistula you create, and your outcomes are a lot better. So nowadays, people probably use vein mapping prior to fistula, unless it's a healthy guy and you can see the vein all the way up to the elbow. Most people recommend getting ultrasound before doing a fistula. So same thing. Your outcomes of fistula is a lot better if you get ultrasound mapping prior to your fistula. This is an interesting study. Wells and all look at 145 patients. and found out about 30% ultrasound doesn't give him enough information to get vein mapping. If he is happy with physical exam, that means he can see the vein, the artery is good, palpable pulse. It's unlikely ultrasound can make a difference. However, in the patient that they are not happy, ultrasound actually help them. They can know whether the vein and artery is adequate for fistula. So this is a sheet for hemodialysis fistula maturation. This is the largest randomized controlled trial NIH is sponsoring currently to look at the outcome of fistula. So these are the things that they look at. The thing that I talk about are the things that they usually look at. So they look at all the diameter of cephalic, basilic, and the forearm vein. They look at the brachial artery, radial artery, and the arch. They actually look at calcification. This is more to help with their trial, I think, rather than for routine clinical practice. But artery with severe calcification is unlikely the fistula will mature. They look at the blood flow. The number they're looking at is more than 50 cc per minute. So the higher flow, the arterial flow, the more likely your fistula will be successful. So same thing, talk about central stenosis. They want to know whether there's indirect sign of stenosis or occlusion. And this is the largest study, and the result is not published. But I thought it was interesting to show you guys what they look for on the big trial. So in conclusion, we know that vein mapping is important for dialysis access creation and improve the outcome. 2 ways. Number one, increase the creation of fistula rate, and number two, increase the outcome of the fistula that we create. This is a good point. If your exam is good and you're happy, so for example, you have good palpable pulse and the vein is very superficial, like one of yours, that you can see the vein, it's unlikely the ultrasound will change anything. But for most of our patients, where you can't see the vein at all, it's very important for us to get ultrasound. A lot of old school surgeons is against the idea of doing routine vein mapping. However, I think even in those surgeons, if you're not happy with the physical exam, it's probably important to get an ultrasound prior to your fistula creation. Thank you all. Any questions? All right. Dr. Zang?
Yeah, that's very very, very useful. I just want to ask you, mention that if you've got an adequate physical examination, you don't need a ultrasound. What physical examination you consider as adequate? What you consider unadequate? Some patients have a central vein stenosis, and they don't have significant swollen, and you still got a very good pulse, then do you do ultrasound or not? You don't know if the patient has central vein.
So a lot of paper for selective, they are choosing people with first fistula creation. So never had a history of fistula. And usually it doesn't have central stenosis. They look for the criteria that I mentioned. Palpable arterial pulse. You can see the vein, it's not tortuous, it's straight, and there's no history of swelling. So those people, they'll actually go ahead. But if you talk to old school surgeons, that's what they do. And they have reasonable success. You can't say that they're wrong, but nowadays, because of the thing that you mentioned, we all do ultrasound. Michelle?
Upper extremity. Then we order vein mapping in the same upper extremity because the radiocephalic graft is included or radiocephalic fistula. Then are you planning to create a brachiocephalic fistula then? Is that the reason why you are evaluating that arm again?
So the principle is you go to the non-dominant arm and you choose the best possible vein. Could be dominant, could be non-dominant. You go for the best vein. You try to start at as distal as possible and then go up. And you try to stay on one arm if possible. So we are looking for something that we can do. We can be creative. So depending, although the typical is radiocephalic, brachiocephalic, it could be in the middle. Then we get the vein and hook it up. It's possible. So we are looking for something that we can create a fistula, pretty much. And in arm with previous surgery, the anatomy is different. So those are things that we look for too. We're looking for maybe the artery is occluded, it's possible. Maybe the central vein is occluded because the clot extends from cephalic down to central. Those are the things that we look for. But we are trying to find something to do a fistula, if possible. Thank you.